Topics in Orthopedics, Common Fractures and Conditions, written and narrated by Carl R. Boyd. Colles fracture. A Colles fracture is defined as a distal radius fracture with dorsal angulation, dorsal displacement, and radial shortening. Colles fracture is caused by falling on an outstretched hand with the wrist and dorsiflexion. There's the characteristic silver fork deformity. Distal radial fractures can be managed either non-operatively or operatively, depending upon the fracture pattern and the patient profile. Treatment options include closed reduction and immobilization with splint or cast, closed reduction and percutaneous pinning, or even open reduction and internal fixation. Scaphoid fractures are the most common carpal fractures and tend to occur in younger, active individuals. Patients typically present with rest pain following a fall onto an outstretched hand. Scaphoid fractures most commonly cause pain and swelling at the base of the thumb in the anatomic snuff box. Fractures that are non-displaced can be managed non-operatively with immobilization in a cast. A boxer's fracture is a fracture of the fifth metacarpal neck, named for the classic injury mechanism involving direct trauma to a clenched fist. Immobilization with an ulnar gutter splint is the definitive treatment for closed, non-displaced fractures without angulation or rotation. If greater than 30 degrees angulation, reduction is accomplished. A green stick fracture is a partial thickness fracture where the cortex and periosteum are interrupted on one side of the bone only. Green stick fractures occur most commonly after a fall on an outstretched arm. Green stick fractures are most likely to be found in the pediatric population under 10 years of age, but can occur at any group. Cast immobilization of the long bone green stick fracture should be approximately 6 weeks long. A slipped capital femoral epiphysis, or SCIFE, occurs in teens and preteens when the femoral epiphysis is abnormally displaced posteriorly and inferiorly relative to the femoral head and neck. Often there's no history of trauma or injury. The cause is unknown, but occurs most often in periods of rapid growth. The patient will usually have intermittent pain in the groin, hip, knee, and/or thigh for several weeks or months that usually worsens with activity. They may hold the affected side in a position of increased external rotation, resulting in an out-toed gait. Treatment is with open reduction and internal fixation of the slipped epiphysis. Femoral neck fractures are a specific type of intracapsular hip fracture. The femoral neck connects the femoral shaft with the femoral head. The hip joint is the articulation of the femoral head with the acetabulum. The blood supply of the femoral head is an essential consideration in displaced fractures as it runs along the femoral neck. Femoral neck fractures are associated with low-energy falls in the elderly. In younger patients sustaining a femoral neck fracture, the cause is usually trauma secondary to high energy, such as a fall from a substantial height or a motor vehicle or accident. Operative management is the treatment of choice. Posterior knee dislocation. High-energy trauma is usually required to cause tibial-femoral dislocation at the knee joint. The popliteal artery is at the highest risk of a vascular insult due to tibial-femoral dislocation, and up to 40% of patients will sustain an associated vascular injury. Perineal nerve injuries occur in more than 20% of patients. Knee dislocation is an orthopedic emergency requiring acute closed reduction followed by evaluation of the vascular status. Congenital hip dysplasia. In congenital hip dysplasia, essentially the acetabulum is too shallow and the hip dislocates. The incidence is 1 per 1,000 births, with firstborn, females, and breech presentation having a higher incidence. Uneven gluteal folds aids in the diagnosis of dislocation. Clinical features vary from mild hip instability and limited abduction in the infant to asymmetric gait in the toddler. Maneuvering the hip may result in a clunking noise if the hip is dislocated. Hip ultrasound is used for diagnosis. For patients aged 1 to 6 months, abduction devices can be tried, including the Pavlik harness. Closed reduction with spica cast and even open reduction is used for those over 18 months of age. Carpal tunnel syndrome. This condition occurs when the median nerve is compressed as it traverses the carpal tunnel, leading to an entrapment neuropathy. Occupations involving frequent computer use, exposure to vibrating equipment, or repetitive movements significantly elevate the risk of developing this syndrome. The initial signs of carpal tunnel syndrome are pain, numbness, and paresthesia within the median nerve distribution, the first 3 fingers and the radial aspect of the 4th finger. The Phelan test, also known as the reverse prayer, involves the patient fully flexing their wrists by placing the dorsal surfaces of both hands together, with the elbows flexed, and holding this position for 1 minute. A positive test is marked by pain and paresthesia in the fingers innervated by the median nerve. In the Tinel test, tapping directly over the carpal tunnel elicits a response from the median nerve. The test is considered positive if symptoms occur. Electromyography may also be incorporated to assist in surgical decision-making and rule out alternative diagnosis. The primary treatment approach for mild carpal tunnel syndrome symptoms involves conservative therapy, including glucocorticoids and nighttime splinting. Patients unresponsive to conservative treatments are those with severe carpal tunnel syndrome, confirmed through EMG testing, may require surgical intervention. Ganglion cyst or mucin-filled synovial cyst. Ganglion cysts are most commonly found, 70% of the time, on the dorsal aspect of the wrist, arising from the scapholunate ligament or the scapholunate articulation. The majority of ganglion cysts are asymptomatic, but patients may seek treatment because of their unsightly cosmetic appearance. Patients may present with pain, tenderness, or weakness that's exacerbated by wrist motion. Ganglion cysts usually present as a firm, well-circumscribed, freely mobile mass, approximately 1 to 3 centimeters in size. Asymptomatic patients can be observed and reassured that ganglion cysts are benign and may spontaneously regress. Non-surgical treatment may be attempted depending upon the location of the cyst. Dorsal wrist ganglion cysts can be aspirated, but there's a much higher recurrence rate than with surgical excision. Surgery is indicated for patients with continuing symptoms who have failed conservative management. Dupuytren's contracture is a myofibroblastic disease that affects the palmar and digital fascia of the hands. It usually results in painless cords that eventually lead to flexion contractures of the fingers. Dupuytren contracture is usually seen in whites, and the disorder is often bilateral. When unilateral, the right side is more likely to be involved than the left. As the cords thicken and shorten, they cause fixed flexion contractures of the fingers at the MCP and PIP joints. The 4th digit is most often affected. The tabletop test is performed by having the patient attempt to place the palm flat on the exam table. If there's any flexion contracture deformity, the patient cannot straighten the fingers, resulting in a positive test. Physical and occupational therapy may be helpful early. Corticosteroid injections may be beneficial for some, especially those with painful nodules. Collagenase injections provide a minimally invasive treatment derived from Clostridium histolyticum. Surgical fasciostomy, when indicated, can either be partial or total. Morton's neuroma. Morton's neuroma is a compressive neuropathy of the forefoot interdigital nerve. It's not a true neuroma, as the condition is degenerative rather than neoplastic. The most common locations for interdigital neuromas are between the 3rd and 4th metatarsal heads. The most common symptoms are plantar pain between the metatarsal heads that are aggravated by walking and wearing tight-fitting or high-heeled shoes. The patient will often say that it feels like I'm walking on a rock. Diagnosis is confirmed by ultrasound. If non-operative management fails, orthotics, steroid injections, alcohol injections, then surgery is indicated. A Volkmann's contracture is a claw-like deformity of the hand, fingers, and wrist, which occurs as a result of trauma, such as fractures, crush injuries, burns, or arterial injuries. Following this trauma, an increase in compartment pressure causes a deficit in the arterial venous circulation in the forearm, which results in decreased blood flow, and hypoxia, which can lead to damage of the muscles, nerves, and vascular endothelium. This results in contracture of the muscles in the forearm with a resulting claw-like deformity. For acute compartment syndrome, fasciotomy is performed. Chronic contractures are treated with stretching and splinting, physical therapy, and if no response, surgery. Unhappy triad knee injury. This unhappy triad consists of concomitant injuries to the medial collateral ligament, anterior cruciate ligament, and the medial meniscus. This type of injury often occurs in contact sports such as football and rugby with a lateral blow to the knee. There is severe pain, bruising, and edema associated with popping or clicking noises on extension. Treatment of the unhappy triad usually requires surgery with postoperative physical therapy. A Baker's cyst is a fluid-filled sac that forms in the popliteal fossa on the posterior aspect of the knee. In adults, Baker's cysts are commonly associated with degenerative arthritis. Patients may present with tightness, discomfort, or pain behind the knee. Diagnosis includes plain radiography and ultrasonography, followed by MRI. A mass may be prominent and palpable with full extension while standing. Treatment options include rest, activity modification, NSAIDs, physical therapy, aspiration, and steroid injection. If conservative measures fail, then arthroscopic cyst decompression and meniscectomy is performed. In non-degenerative cyst, open excision is performed.